all had a refreshing lunch and some great conversation and re-energized after this for next insightful session. So, as we step into the post-lunch segment, we now turn our focus to theme that is rapidly becoming the backbone of modern healthcare. That is digital health and interoperability. This session will explore how digital health platforms and interoperability systems are transforming healthcare delivery across hospitals, diagnostics, and care networks. The discussion will focus on data integration, AI-led solutions, system interoperability, and the real-world challenges of building a connected, scalable, and patient-centric healthcare ecosystem in India. Now, I would like to take this opportunity to invite our moderator who will guide this important and forward-looking conversation. May I invite Mr. Saurabh Gupta, Regional Director, KIMS Hospital. Now, I would like to invite Mr. Sanjay Jain, Director at Appeal Systems Private Limited. I think we all are energized after our lunch, so I request a big round of applause for our speakers. Dr. Sushil Meher, Head Health, IT and CISO, KIMS Limited. Also, we can have a round of applause for our speakers who are coming on stage. Mr. Mohit Tandon, Vice President, Information Technology at Metro Group of Hospitals, Noida. Professor Dr. Vivek Gupta, Senior Intervention Cardiologist, Apollo Hospitals, New Delhi, Chairman, IECR, Indo-European Course, President, M International Heart and Healthcare Foundation. Dr. Rajiv Tandon, Executive Director, The Health Continent. Over to you, sir.
I hope the mics are working fine now. Good afternoon. Thank you for this opportunity. Thank you for entrusting me to moderate the second difficult session. The first most difficult session is before the lunch because everybody wants to have lunch. And the second one is after the lunch because people tend to feel sleepy. But believe you me, this is actually one of the most important and exciting sessions. And we are talking about something which is now the buzzword in the entire global healthcare scenario. So we are talking about digital health and interoperability, which is the buzzword. And I can see the panel which has been curated is actually quite mindfully done because we have people from some of the biggest public hospitals. We have physicians on board. We have people who have been doing HMIS integration for the last 20-25 years when it all started. So it has been quite beautifully curated session. Now, the flow of the session for the panelists would be, if I may, sir, Dr. Gupta, sir. So what I will be doing, we have around 29 minutes. So, pardon? Yeah, only. Yeah, this can be discussed on and on. So what I will be doing is that I will set a brief context and then I'll come to each one of you and you will be free to talk about your thoughts for 3 to 4 minutes. Let's stick to that. And after that, I would like, yes. And then again, I would like to come back for a rapid fire round just to get your final thoughts. And if the time permits, we'll open up for the audience to ask some questions. Great. So, just to give you some data, because I was very excited when I saw the panel and topic. We all know that Indian healthcare is actually at the cusp of transformation, and it is undergoing a fundamental shift. What is happening is that healthcare is moving closer to everybody's. tier 2 and tier 3 cities are the next hub for healthcare. From episodic hospital-centric care to continuous and connected patient care. That is the new mantra. And patients today are moving across multiple providers, even public to private and private to public. And this shift actually is the reason why we are talking about digital health and interoperability. Interoperability is not just enabler, it is a necessity now. And our government has already taken big step towards it. The Ayushman Bharat Digital Mission, which has been created as a public health backbone. And where India stands today is, we have already crossed 55 crore ABHA account ID, which is significant. We already have more than 6 lakh facilities on ABDM, and we have more than 5 lakh healthcare professionals already onboarded. And unified health interface is already there, and an architecture of national consent is being designed. So these are very exciting elements from Indian government which have taken place. And interoperability simply means that the data flow has to be seamless and securely flow across the system. That is the ask for continuum of. So without wasting a lot of time, I would like to jump on to my learned panel. So I'll start with Mr. Jain. So Mr. Jain, I have been hearing about Akhil system, I think for the last 22 years I have been in the industry, and you have one of the largest homegrown system and also the maximum number of installations in India and Southeast Asia, in fact. So I would like to actually understand from you one thing, which is, as a technology provider, how do you see digital platform enabling interoperability, and where do healthcare organizations typically struggle in your experience for the last 25 years or so during implementation? Because we have seen that we do very well when we strategize, but at the implementation time, new issues come. So over to you.
Good afternoon, Saurabhji. Good afternoon, everyone. My name is Sanjay, and I've spent almost 3 decades, 31 years in the healthcare industry. 94, 95 started my journey, and today is 2026. Very pertinent questions Mr. Saurabh has asked. I give you my personal experience. My father was a chronic asthmatic patient. More than 20 years he suffered. And every time when we go to the hospital, we have to carry the papers. There is no system was there which can talk, which can digitize the data, or can bring the data to one place to another place. So I would like to congratulate Government of India to bring this ABDM initiative. ABDM is the biggest platform which I have seen bringing all the hospital data or clinical data, making one hospital to talk to another hospital. So if you look at from that interoperability perspective, hospitals have to adopt ABDM's norms. Milestone 1, milestone 2, milestone 3. These are 3 milestones are there. If you go for those adoption, most of the things you will try to cover. Definitely it's not that simple, because most of the hospitals have got fragmented systems. Their LIS is different, their EMR is different, their appointment system is different. So all those things may not be same way they are going to talk to each other. Connectivity you need to be there between those systems are there. Apart from that, the biggest challenge is standardization of data. There is no standard data being followed in the industry. You go to one hospital, you will find there are 10,000 services codes are there. You go to another hospital, there is another 10,000 services code will be there. The investigations nomenclature will be different. Medication nomenclature will be different. By this, interoperability cannot possible. You may see the data, you can access the PDF file, but if you want to deep integration between one element of data to another element of data, standardization of data is must. So without standardization of data, the deep interoperability will not be possible. For that, one has to follow the coding of SNOMED codings are there, for clinical outcomes are there. Is the coding for linear code for diagnosis, the ICD codes, PPD code, and so on. So standardization of data is very, very important. one has to follow that part. By doing all these steps, the third part for interoperability is the application should be API ready or API first. Your application is not API, HL7 or fire compliance or fire bundle, this interoperability cannot be possible. Unfortunately, because of the long period of the development have taken place in the industry, there is no standard being followed. Every application design is own way. Now the time has come to go to the one standard, make it fire or HL7 compliant application. That's my first answer of the answer of the question.
No, very relevant. In fact, I can relate to one of my experience. It's the commonly said ego, garbage in and garbage out. Because if you cannot standardize even the inputs, then the output will be a disaster. So thank you very much.
Regarding second question, which you have asked about the implementation challenges, I tell you honestly, this is one of the biggest challenges any industry has seen. And if you look at it from the healthcare perspective, the challenges are more. Most of the time, hospitals got single agenda or single item, which I've seen in the industry to destroy the revenue, destroy the billing. They don't have any focus, any clarity on the patient-centric journey. So unless you have a clear path, clear vision, complete roadmap, implementation going to have challenges. Second part, which I've highlighted about it, your priorities. What priorities you are going to decide, what is your further plan to destroy the organization, that should be clearly defined. The third point, which I have seen in my industry or my experience, is that the commitment of the top management. If you are implementing it, it's not an implementation of an IT department job. It's a transformation of the entire organization. If you look at it from that perspective, the chairman, the CEO, everyone has to be part of this journey is there. I'll just give you an example. In 2005, we have done an implementation, very big implementation of Apollo Group, where the EMR, the chairman of that group wanted the EMR to be implemented by every doctor. Every patient has to have an electronic prescription. Every day, chairman used to get the SMS in the morning, how many doctors have used, how many doctors have not used, what is the reason why they are not using it. And I'm happy to say 20 years have passed. Every patient data is there in the system. So we have commitment on top, the challenges become very easy. Then there should be change management, the training methodology. If you do it properly, everything is possible.
Thank you. I'll come back to you. So Dr. Sushil Meher, I think it's again a privilege to have you on the panel. You represent one of the most reputed and biggest public institutions India has ever built. So my question to you is, as a national and public healthcare provider, how do you balance data interoperability, ensuring that patient privacy is there, cyber security is there, and the trust of the general public upon institutions like yours is intact?
Yeah, good
3 to
afternoon.
4 minutes, please. Yeah.
Good afternoon, everyone. And thanks to the BOH to invite me in such a wonderful event. In this industry, IT industry, in healthcare, I am like last 34 years. I know every in and out of the government's movement as well as the hospital. First HIS been implemented in AIIMS New Delhi is 1988. And I am the part of that team. And till date also, I am part of it. Now we come to the government. Government has started 2005 to make a single record for a citizen. And that document has been prepared by the Ministry of IT. And IT departments, they felt that they do not have the domain knowledge, they are unable to do it. So 2019, Ministry of Health has started EMR standard for the national. And till 2013, they are unable to implement it because of a lot of bottlenecks are there. So they thought it is not possible to make a single medical records for each citizen, because central depository system is very difficult to implement it, and giving such kind of infrastructure, it is just a difficult task for the government. So that's why they have started that another committee, that is ABDM, has come up in, and they have placed the role. They have done a wonderful job. the records where it will be lay there, but when the patient will want to retrieve the records, he can retrieve it. Because the basic concept and the legality is that patient itself is the owner of the data, not the hospital. Hospital is the custodian. So now it has come up that these data, how it can move from here to there. Right now, the data is not moving. It is moving to the patient's domain only. And we are the highest number of AVA ID creator in the country till date. Without AVA ID creations, we do not do any registration of any patient. That is our principle first, because we need interoperability. Because when patient is moving, it is not doing all the records in one place. It is in different place. And put it in one place, it is a difficult task. Because each hospital, they are using different applications, different nomenclatures, different metadatas, they are using it, and it is a very difficult task. Government has already been given the MDDS, metadata and data set. Hardly any people, they follow it. If will follow, see, the record is laying in the A place, and it has to move to the B place, B hospitals. A hospital, B hospitals. If the metadata is not matching, how it will be interoperable? The nomenclature is not matching, how it will be interoperable? So that is the main challenge. Till that challenge is there. To come over this challenge, ABDM has come up. Whatever metadata you are using, there is not an issue. You can retrieve the data by the patient only. When you'll get the OTP, and he can get the data. Now you have told me that cyber security and privacy. There are three pillars in healthcare is there. Security, confidentiality, and privacy. It is already in EMR standard of Government of India, it has already been mentioned that how this can be applied and what standard has to be followed. When you are talking about security is a big challenge in digital platform. Now, another standard has come up, that is currently it has been already been passed out from the government, that is DPDP Act. And when DPDP Act is going to be implemented, it is a big challenge that your data has to be secure. That's why the standards which has been given it, we have to zero trust architecture supposed to be there. Another one is that whatever API you are using for the different application to application or database to database, that cases also API security will be there, application security is supposed to be there, and lot of other things which has been required to be there, data loss and prevention is supposed to be there. And it is a big challenge for the organization because it is a very expensive. And each devices is integrated. When devices is integrated, it is the third party of the devices which is been not coming to their security systems. That is one of the big challenges there. Another one is that the access control. Which data who has to issue, who has to access it. When DPDP has come up, that if without taking patient consent, another not treating doctor, they can't say it. And here, earlier what it is. In DPDP Act, when data is digital, then law is implied. When data is in paper form, it is not being enforced. When data is in digital form and the other doctors want to take the referral cases, in that cases also referral certifications already been supposed to be there and consent form has to be signed. So the concerned managers, before that, he's supposed to make a whole workflow and process, and it has to be certified and it is communicated to the patient that it can be done. Without that, it cannot be possible. This is one of the big challenge we have.
Great. I think in the interest of time, we'll move and we'll come back.
Yeah.
I think it is very reassuring to hear it from your mouth because, AIMS actually represent, the public sector as such, the public hospital of India. And a lot of people, trust came. So it is very reassuring to hear that type of measures you have taken your data, patient privacy and the data security. Okay, I'll move to Mohit. Mohit, you represent one of the upcoming, groups in northern India. So, from an execution standpoint, what are some of the practical steps hospital can take today, in your experience, from multiple fragmented systems to a more interoperable digital ecosystem?
So first of all, good afternoon all, and thank you Voice of Healthcare for inviting me for this panel. And I should say, Saurabh, this is a great question and a very important one. And I think I am the good person to revert, since it's been more than 2 decades that I am implementing HIS in different hospitals in India. So the main interoperability reason what I feel the practical steps or the steps I should follow would be that a CIO should have one person deputed or himself who can take the decisions for the HIS. That which HIS we have to procure, how we have to procure, and once it's decided, we must have the standardized data that we will be porting. Many hospitals have the older data which is in the junk formats, the cleansing exercise is not being done, and so on, and the same data goes into the new HIS, in which we face a lot of problems. The next important point is the interfacing part. So in the older days, we don't have the HL7 integration, in which the two machines communicate with each other, and the problem lies with that. And interface is today also is one of the major problem areas in healthcare. One more thing, especially for the EMR part, if we have to execute that, we must have a clinician on board who should be driving the entire workflows with us and help us for the adoption of that.
Great. I think very precise. Thank you. And just to take it forward, we also have a clinician on board on the panel. So let's hear from Dr. Gupta. So, sir, yeah. So my question to you is, as a cardiologist, there are a lot of technologies which are flowing in the market. We have a lot of AI tools, clinical decision support system, patient monitoring, and digital therapeutics. How do you think they have started to make difference in cardiac care? Mike.
First of all, thankful to the organizers for giving the opportunity. I have taken a special permission to show 2 slides because it's a very interesting topic, and I thought I can finish off in 3, 4, 5 minutes. So I'm cardiologist. I do angioplasties. I am interventional cardiologist, and we have been doing for last 25 years in Apollo Hospital. Before that, I was working in France and do regular life-saving stent angioplasty, which is a common thing, pacemakers, ICDs, which is a prevention of sudden cardiac death, heart failure patients, and also pacemakers and sometime EP and balloon valvuloplasty and TAVI, which is a transcatheter aortic valve implantation, which is a new technique for replacing the heart valve without opening the chest. So all these things I'm doing in Apollo, and I'm thankful to the panel to have this. So I'll show you how the AI can really help. So I told you about self. And so in modern cardiology, technology is standard in care. I think you can move forward because they're very important slides. You can look into it. So AI driven, so how AI can help, or rather technology or digital health. I'm also the convener, national convener of the DG Council of Cardiological Society of India. So that way also I have. So AI driven clinical decision support, AI algorithm are now second opinions that can help prevent diagnostic errors and optimize treatment. Precision imaging, deep learning tools, for example, echocardiography. Echocardiography is like an ultrasound of the heart. And here, if you have AI, then we can reduce the time of diagnosis from 30 minutes to under 5. Early detection, AI can identify subtle signatures of atrial fibrillation. What is atrial fibrillation? Atrial fibrillation is an abnormal rhythm of the heart, where the upper part of the heart start beating at the rate of 300 or 250. Lower part of the heart start beating at something like 80, 90, 100 to or 150, sometimes which is fast ventricular response. And this atrial fibrillation is one of the cause of stroke. So if we can diagnose atrial fibrillation earlier, we can prevent a lot of strokes. Personalized therapy like Mayo Clinic AI dashboard, electronic health records, Then remote patient monitoring, although you know that we are using Apple Watch, but RPM has moved from simple data collection to early warning system for high-risk patients, reduction in hospitalization. Clinical evidence show that RPM program for heart failure can reduce hospitalization by up to 65%, heart failure patients. So if we can diagnose early, we can treat at the home rather than getting the patient to the hospitalization and then, of course, reducing the cost of the patient as well as the hospital. Implantable devices, wireless sensors and the pacemakers and defibrillator. When we put a pacemaker, it has got a wireless sensing also. The whole is being sensing. And if we can put AI into that, we can provide continuous updates on heart rhythm and fluid status, because a small change in the fluid of the lung, which goes into the lung in the heart failure patient, can lead to breathlessness, and that's, of course, one of the causes for hospitalization. And we can diagnose early. Then digital therapeutics, hypertension control. If we know we can have something like that which is brought in the body of the patient of hypertension, we can increase or reduce the doses of the hypertensive medications at home only. Virtual cardiac rehab. This is a digital program for the flexible alternative to traditional rehab. Medical adherence, this is important because if you see in our India and all of the world, is it just diabetes or hypertension? Most of the time, it is only 30 to 40% who are actually well controlled because they don't adhere to the medication. So if we can have a life report adherence such as 90%, software provides real-time reminders, educational nudges, advanced interventional tool, non-invasive planning. You know, when we are doing angioplasty, it's a very important point. When we do angiography, the patient always asks, कि angiography करेंगे तो angioplasty करना ही पड़ेगा. ऐसा नहीं है. This is not true. In our practice, in my practice personally, not more than 50% will undergo angioplasties because we do stenting only when the blockage is more than 70 to 80%. 50%, 30% we keep on this. So this thing also can be found out by CT scan. If we have normally we were not able to do that because we have to do catheter angiography for that. But and then of course coming back to another point, which is heart failure and arrhythmias. Heart failure is the most important cause of death in cardiac patients. Heart failure means it is not arrest. For the public, I would like to differentiate between cardiac arrest and heart failure. Heart failure means weakening of the heart. It is the weakening of the heart, but they are prone for cardiac arrest, and that is why we put out AICD, which is automatic implantable cardiac defibrillator. So if we have something like AI from reactive to proactive, predictive alert system, invasive hemodynamic monitoring, which can be done through a wireless sensor only, AI-enhanced screening and novel digital. The last part only, just last slide. For arrhythmias, for atrial fibrillation, the focus is shifted towards passive large-scale screening. I told you atrial fibrillation is otherwise a benign condition, but it is one of the major cause of the stroke. And then, of course, if you can diagnose and screen before it actually happens, because intermittent atrial fibrillation will be missed by Holter monitoring. Holter is a 24-hour ECG, or 3 hours ECG, sometimes 7 days ECG. But even then it can be missed. Intermittent atrial fibrillation can lead to stroke. With this having more AI using AI time travel, advanced procedural guidance and detection of inappropriate shocks. The last point important I'll do. When we put AICD, I all know, should know then and educate the patient population. If you have a heart failure, ejection fraction less than 35%, you will need to have something because you are prone for sudden cardiac arrest and death. The patients. So if we can put an automatic implantable cardiac defibrillator, which is like a pacemaker, it will keep on sensing the arrest or arrhythmia, and then it will give a shock, like an automatic shock, and it's a second life to the patient. A lot of my patients have undergone such treatment and they are actually living. So through all these things and this Voice of Healthcare, I've been able to tell you a little more about how AI, how digital health, how digitalization can actually help more and more patients to prevent lives, especially in cardiac patients.
No, thank you, Dr. Gupta. It has been very insightful. And I think majority of the hospitals are now trying to get into AI-based tools. And some of them are very helpful. Like we use, smart beds. And we have achieved zero code blue hospitals at many places. So I have seen some of these things really work. Thank you very much. I think a lot of people would like to connect with you after the session to get your views. Okay, in the interest of time, I'll come to Dr. Rajiv. Sir, you run, a great platform. I was just going through your platform, and you talk about holistic healthcare, universal healthcare. And I think that's the need of the hour, because if we talk about digital health and interoperability, one thing which it should target is that the healthcare should be universal, and patients should seamlessly move from one system to another. So my question to you is, sir, looking at the broader healthcare system, what systemic changes are needed to make interoperability sustainable across public, private, and digital health stakeholders?
Thank you, Saurav. What I feel is that when you're talking of digital interoperability and universal health coverage, what you need to decide is, and heard the first couple of speakers talk about digital from basically a digital lens. They talk about APIs, they talk about platforms, they talk about challenges of interoperability because data doesn't talk to each other. But the aim of ABDM or the aim of ABA ID is to ensure that healthcare can reach the last mile. And what we are seeing at the moment is when you are focused on digital in digital discussions only, the public health outcomes get lost. What we will need to do is, and if we pick up ABDM only, we would have to try to ensure interoperability through a health system strengthening up. There are clear mandates that WHO has defined on what is needed to ensure that the health systems get strengthened and a newer innovation gets integrated. We have to ensure, and I loved hearing what the previous speaker spoke of, what is happening in the Pinnacle Ivory Tower Hospital. And even they are saying that a patient, when he moves from one site to another, is having challenges as far as his electronic health records are concerned or his actual health care is concerned. We are seeing that there are states in India which are doing much better with interoperability, with digitalization, with universal health coverage as compared to others. What we will need to do is we would need to ensure that frontline workers, not only people who are doctors in ivory tower hospitals, also get capacitated as far as use of digital, use and understanding of what does the word interoperability actually mean. Which data has to be seen for what purpose, in which patient, and how do you transform all of that, analyze collectively, and ensure confidentiality, ensure that the patient-centric decisions are taken with his or her data and not misused. We have seen a lot of misuse of collective data also happen. What we feel is that once you have a system where, because ABA ID and ABDM have seen much more use as far as financial tracking is concerned. But preventive and promotive healthcare still needs to be looked at. And what we feel is those are aspects that have to be highlighted now. Those indicators, and somebody talked of the nomenclature that are being used in different hospitals are actually different. See how that changes into actually public health care, which, as you rightly mentioned, goes universally. There is a difference between a private sector and a public sector. There's a difference between a healthcare provider and a person who's sort of a digital expert. We will have to ensure that nomenclatures, methods, systems all go through a health system strengthening methodology, and that is where we'll actually benefit of digitalization.
I think thank you very much. You have touched upon the most important aspect, training of the people. Because, we only talk about hardware, software, and, training of doctors. But until the last man standing understand what is patient privacy and, how the data needs to be treated, this entire system will fail. So thank you very much. So the time is already up, but what I would like to do is I will just come to each of the speaker for one last word, and the question remains same. So starting from you, Mr. Jan, one word to describe the biggest barrier to interoperability in India today. Just 3 seconds.
I believe commitment.
Okay.
If commitment is there, everything is possible. systems I have seen for 30 years, the people who have committed for the digitization of cost, they have succeeded.
Okay, thank you. Dr. Meher.
Yeah, the government, what it has been given for the interoperability standards that's supposed to be followed. Because that has been designed meant for the interoperability. And nobody's followed because health is a state subject, not the universal subject. That's why it is a problem.
Thank you. Mohit.
One word I think is fragmentation. So different vendors are there in India. They have different databases which are not connected to each other.
Okay. Dr. Gupta.
Cost and I think the availability of the devices, especially in the rural areas,
Okay.
small district hospitals. We are talking about, what you are talking about is a 5-star, best of the super specialty hospitals. But our major population is being treated by 70% or 80% by the system which is not having such thing. Therefore, the government has to allocate specific budget so that all these people, patients who are poor patients also and who cannot come to Delhi or Bombay, then this should be.
Thank you. Got it.
Government side,
So-
government.
I would use the word confidentiality and privacy.
So, do we have time for questions or we are? Okay, great. So, thank you very much. I think very exciting deliberations, and I think everybody has gained from this session. If you have any questions, you can talk to any speaker after the session. They are all around. Thank you so much. Thank you.
Thank you so much, sir. Thank you so much for this insightful discussion, and you have moderated really very well. Now, I would like to invite Mr. Saurabh Gupta to kindly come on center of stage to felicitate the co-panelists. Mr. Sanjay Jain. Mr. Mohit Tandon. Dr. Sushil Meher. Professor Dr. Vivek Gupta. Dr. Rajiv Tandon. Now I would like to invite Ms. Pinky Chaha to please come on stage and felicitate our moderator, Mr. Saurabh Gupta, for this excellent moderation. Let's have a group picture. I request all the panelists to please come on center of stage for a group picture. Thank you. Thank you so much. Thank you, everyone. Ladies and gentlemen, before we proceed for our next session, I believe we all are recharged after the lunch and then we had an insightful session out here. But just to keep you engaged and have fun in between, I have few more questions with me. So I just request everyone to stay active and attentive as I'm coming up with few more questions. So the next question on screen is, what does ABHA stand for under India's digital health ecosystem? I'll be coming to you. You just keep your hands raised. Okay. Who's there? Who's there? The girl, I think she rose her hand for the first.
The accredited basic health.
Accredited basic health. Any more option?
B option.
Okay. What exactly is Ayushman Bharat?
Like
About Ayushman Bharat Health. Okay. Ayushman Bharat digital account.
it's like a exactly.
See, I believe these options are very easy, so I would need an explanation to support this. तो मुझे पता चल जाएगा ये फटाफट गूगल नहीं किया हुआ है. B. B is accredited basic health access. Health account. I need an explanation. Who will give me a proper explanation for this?
Hello. Yeah, the option is B, Ayushman Bharat Health Account. It's actually a 14 unit number which acts as a healthcare digilocker, prescribing the prescription, the appointment that we do, the later appointment, the health reports. It's like a digilocker, health digilocker. My name is Shivani. Yeah.
Perfectly right answer, and that's a 14-digit health account, unique ID which have your prescription, all the records for the doctors. Can we have a gift, please? Thank you. So we have another question. The next question is, which mission is responsible for India's digital health infrastructure? A, Digital India, B, Ayushman Bharat Digital Mission, Ayushman Bharat PMJ, and NHM. You don't have to announce.
Ayushman Bharat Digital Mission.
Anyone who knows the right answer for this? Have an explanation for this or an answer? And any supportive fact or information? I need an information also. Some factual information based on it. Because I think these quizzes are quite easy, so everyone would know the answer. So you would vote for C. Can we have the right answer on screen? B. Yes, it's the right answer. Can we have a gift? She took the name correct, but the option was this. Thank you so much. This brings us to the next session we have on this, and I believe we'll keep on doing this, so anyone who hasn't received anything, stay attentive and active. We'll be having some more question answer round.